Congratulations, you've made it to neuropathology. I'm Stephen Alsop, and again, just like we did with anatomy and physiology, we will try to approach a lot of this information in ways that make it more intuitive and less about rote memorization. Although there are some things which you undoubtedly will have to memorize, the key here is to take the information from anatomy and physiology and try to apply as much of it to what is happening in these disease states. Let's begin. Dementia is defined as a progressive global impairment of intellectual function, and it is among the most important topics in this entire chapter. It includes the loss of short-term memory and at least one other cognitive deficit, such as aphasia, apraxia, or agnosia. Of course, you can also have impaired executive functions. Now, in the elderly, it's very important to distinguish dementia from delirium. So what is the difference? Well, we can think of it this way. If we were to chart the progression of dementia and delirium, and we had, let's say, cognitive function on the y-axis and time on the x-axis, the first thing you should notice is that the axis is very different for dementia and delirium. Dementia, we're dealing with the time scale of months, whereas in delirium, we're dealing with hours, right? And so what we would expect to see in dementia, sort of this progressive decline of function over a few months. This can actually even stretch on to a number of years. Whereas delirium, we'd expect a very rapid decline in function over a few hours, maybe that improves, and then maybe it diminishes again after a few hours. Okay, so in dementia we have a progressive decline, gradual loss of function, while in delirium we have acute onset that typically waxes and wanes throughout the day. Now there are many causes of dementia, both reversible as well as irreversible. So now let's talk specifics. We'll start with Alzheimer's disease, sort of the big one. This is the most common cause of dementia in the elderly. There's a genetic predisposition to AD that accounts for a small percentage of patients, but is worth talking about. These patients have a mutation in amyloid precursor protein, or APP. They can also have mutation in gamma secretase, which is also known as presenilin 1 or presenilin 2. The mutant amyloid precursor protein, APP, is cleaved into beta amyloid, or A-beta. All of us end up accumulating A-beta with age, which is why the prevalence of Alzheimer's disease increases with age. But A-beta accumulates faster in people with the genetic mutation in APP, so they become cognitively impaired at younger ages. For example, let's look at these PET images. You have a patient with Alzheimer's disease on the left and a normal control on the right. Now there's something very obviously different between these two conditions. This PET is looking for amyloid deposits, and you can see that they are much greater in the patient with Alzheimer's disease and almost non-existent in the age-matched control. Now the APP gene is located on the same chromosome as patients with Down syndrome. And what chromosome is this? Okay, so this is classic, right? This is chromosome 21. And you have 3 copies of that chromosome instead of 2. Now, if we know that in Down syndrome there's an extra chromosome, it makes sense that you would also have more APP, and thus patients who survive to middle age with Down syndrome develop AD. Now, another gene to be aware of is ApoE4. This increases your risk of getting Alzheimer's disease. Interestingly enough, ApoE2 is actually protective, so it decreases your risk of getting Alzheimer's disease. Now, this is thought to be due to its resulting in decreased activity of acetylcholinesterase in the basal nucleus of minert, and this leads to an increase in acetylcholine. Now, increased acetylcholine can be very helpful in Alzheimer's disease. In fact, that is the mechanism of action of the drugs commonly given to help treat AD patients. AD presents with early problems in memory and visuospatial abilities. MRI will show gross cortical atrophy as well as dilated ventricles. You can see that here. There's still a lot of black space. That is not normal. Now, the classic AD patient will be driving down a known road and suddenly find herself lost. Short-term memory is affected first, and as the disease progresses, patients may develop changes in personality and behavior. You can also begin to see hallucinations, delusions, and symptoms of depression can occur. At the end stages, these patients become profoundly disabled, mute, and immobile. Now remember, when dealing with patients with Alzheimer's disease, you're also dealing with their families, and this can have a very tremendous effect on their families and caretakers. Now it's important to remember that the occipital lobe is usually spared in these patients, so what would you expect to see? Well, you would expect to see no visual changes. Alzheimer's is a clinical diagnosis that is made once you've ruled out all other causes of dementia, and the only confirmation you can have of your diagnosis is post-mortem autopsy. Histologically, you'll see widespread cortical atrophy, senile plaques of A-beta depositions, and neurofibrillary tangles pictured here. These are composed of hyperphosphorylated tau proteins. Keep in mind that neurofibrillary tangles are not specific for AD. They can be found in other dementias as well, and you will see that soon. Now let's move on to Pick disease, which is also called frontotemporal dementia for the lobes that are affected. Now, if you think through what these two areas encode, it makes sense that the presenting symptoms for these patients are a progressive deterioration of language, which involves the temporal lobe, right? You can see that atrophied here, as well as changes in personality, which reside in the frontal lobe. You can see some signs of atrophy there as well. Patients may become euphoric, disinhibited, compulsive, or ebulic. And ebulic means that the person cannot exercise willpower or make decisions. Now, these symptoms occur before memory disturbance, which clinically can really help you to distinguish it from Alzheimer's disease. Also, visuospatial function is relatively preserved in Pick disease, so this is sort of in common with what you would see in Alzheimer's. Now, MRI reveals atrophy of the cortex, as we discussed, and you'll see this both in the frontal lobe as well as in the temporal lobe. And here you have a good example of atrophy in the frontal lobe. Now, not only will you see this on imaging, but histologically, you will see characteristic Pick bodies which contain abnormal accumulation of tau proteins, right? So remember, we can see that in Alzheimer's. We can also see it here in Pick. Lewy body dementia is different from AD and Pick disease because it has an element of Parkinsonism. Now, these patients frequently have fluctuating dementia and visual hallucinations as well. The disease is defined by diffuse involvement of cortical neurons with Lewy body inclusions, and those are indicated here. You can also see an absence of neurofibrillary tangles and amyloid plaques, which you would see in AD, so this will help you to differentiate the two. Lewy body inclusions are simply aggregated alpha-synuclein, and they are also seen in Parkinson disease. Unlike Parkinson disease, the Parkinsonism associated with Lewy body dementia is usually symmetrical and minimally responsive to dopamine therapy. So this is another way that you can help tell these two apart. Okay, let's move on to Creutzfeldt-Jakob disease, or CJD. This is a prion disease, and it presents as a rapidly progressive dementia over weeks to months. Now be careful, this is the key element about CJD that can help you to easily differentiate it from other causes of dementia on your test. That weeks to months time scale is something that you will rarely see in dementia. So if you see that, CJD is definitely high on your differential. There's variable focal involvement of the CNS, including myoclonus or extrapyramidal signs such as rigidity, bradykinesia, tremor, dystonia, chorea, or athetosis. Prions are infectious proteins, and they are a very rare etiological cause of dementia. There is no treatment for CJD, and death usually results within 7 months. Again, this is a key fact that can help you to recognize CJD when you see it on the test. Histologically, you would see a spongiform cortex, and you get an example of that here. Lastly, let's discuss some other causes of dementia, a few of which are actually reversible. Within the brain parenchyma, we have normal pressure hydrocephalus, certain mass lesions such as tumors or cysts, and vascular dementia. Now, some systemic causes include hypothyroidism, thiamine or B12 deficiency, and you could see this in what group of patients? The answer is alcoholics. It's just a good association that you should keep at the forefront of your mind. Some other causes of dementia are Wilson disease, liver or kidney failure. You can see encephalopathy or uremia. And lastly, neurosyphilis. Now, in evaluating a patient with dementia, you should always check lab tests to rule out these treatable causes. For example, you might want to send a TSH if you are concerned about hypothyroidism. Maybe you want to send B12 or thiamine levels if you're concerned about that. Liver or kidney failure, you might want to send your electrolytes, get your Chem 7. And lastly, neurosyphilis, maybe you want to send VDRL. Now, what did we say was the triad of normal pressure hydrocephalus? It's wet, wacky, and wobbly. And these stand for urinary incontinence, dementia, and gait abnormalities. Now, why have we mentioned this twice now? Well, it's because it's one of the only dementias that is actually reversible. And this is an important point of distinction on your exam to look out for. In addition to that, practically, if it's reversible, that means you can actually do something about it, which is the neurologist's dream. It is important to realize that about 10% of patients who present with signs or symptoms of dementia are actually depressed, and this is called pseudo-dementia. All patients with possible dementia should be screened for depressed mood, anhedonia, anorexia, weight loss, insomnia or hypersomnia, as well as suicidality. Again, depression is actually treatable, and sadly, as I mentioned, many other forms of dementia are not. Multiple sclerosis is an autoimmune disease that causes demyelination of the white matter in the CNS. Now, although demyelination is ultimately caused by macrophages, which I will illustrate as this Pac-Man looking thing here, the actual initial insult starts with Th1 helper cells. Now, these cells initially react to myelin basic protein. That causes them to secrete interferon gamma, which activates macrophages, which in turn would destroy your myelin. Now, if you think back to immunology, what type of autoimmune reaction does this sound like? Well, this is your classic type 4 hypersensitivity reaction. Now, the symptoms of MS depend on where specifically the demyelination occurs. Patients present with episodic neurologic symptoms like optic neuritis, spastic paraparesis, numbness or tingling in a limb, scanning speech, intention tremor, incontinence, and nystagmus. Now, scanning speech means that there are abnormally long pauses between words or syllables. Internuclear ophthalmoplegia, which was described earlier, is nearly pathognomonic for MS and is most often bilateral. A mnemonic that might help you remember the characteristics of MS is SIN. That stands for scanning speech, several things with I, intention tremor, incontinence, and internuclear ophthalmoplegia, and lastly the N stands for nystagmus. Multiple sclerosis classically affects women in their late 20s or early 30s, but there is a subtype of MS which is more common in men. Now, in both genders, MS usually presents before a person turns 55. These are all important things to be looking out for when you're reading a vignette. Here in this MRI, you can see that there are plaques in the cerebral hemisphere as well as around the ventricles. And this is your gold standard for diagnosing MS. Here's another view of those lesions on a FLAIR scan. Now, the diagnosis is established based on your clinical symptoms as well as these MRI findings that I just showed you. On MRI, you need to demonstrate multiple lesions in the CNS white matter that appear separated in both time as well as space. Now, for the diagnosis of multiple sclerosis, you can also obtain CSF through a lumbar puncture, which would demonstrate mild lymphocytosis, especially after an acute relapse, as well as oligoclonal bands. However, you should know that neither of these two signs are entirely specific for MS. The treatment for acute relapses is corticosteroids. Now, to prevent exacerbations, patients may also use beta interferon or natalizumab. Symptomatic treatment, of course, is also available for the sequelae of demyelination. Now, one thing I want to mention about multiple sclerosis before moving on, because I think it'll be very helpful on questions, is the fact that symptoms come and go. So you're reading your vignette on test day and you get a question where the patient has some neurological symptoms. You maybe aren't able to clearly pin it down, but in the vignette, the symptoms suddenly get better. But later on, this patient comes back with worsening symptoms or additional symptoms. This is nothing to be confused about. MS should be very high on your differential because it is likely the diagnosis. Alright, it is time for a flash quiz. Now, what is the difference between dementia and delirium? Well, dementia is what happens to your grandparents. Delirium is what happens to your spouse. No, okay, seriously, remember that dementia is a gradual process which leads to memory loss and a progressive decline of cognitive abilities. Delirium has an acute onset and typically waxes and wanes throughout the day.